Hello, Precision Clinical Teams. This is Dr. Owen coming to you. Many of you I know and have worked with and been in your clinics. There are some of you that I have yet to meet, those of you in East Tennessee as well as Arkansas. But I hope to remedy that by the end of this year by making it out to your clinics as well. A little bit about myself. Again, I'm Bethany Owen. I am the current medical director as of April 2020 for Precision, as well as medical supervisors for both Middle Tennessee and West Tennessee clinics. I'm board certified in internal medicine and have worked in many settings in the medical field, and I'm very happy to now be at Precision. In thinking about some of the responsibilities of my roles at Precision, one of the things that I wanted to promote was really support for you guys while y'all are the ones that are in the clinics and doing the dirty work of patient care. And I just wanted to make sure that y'all were supported and that you had resources made available to you. I was thinking in terms of a CME type series that would maybe happen quarterly where you guys could watch it. In the future, what I would like to do is get your feedback and find out what things you guys would like to discuss and topics that might be of interest and clinically relevant for y'all. And speaking with one of the nurse practitioners, we had a conversation about possibly doing one on side effects of the medications that we administer, so that it primes you to look for, let's say, labs and knowing which medications can cause certain lab aberrations and topics like that would be of interest and of help to y'all. So be thinking about things that you would like for me to cover. I want us to be, abreast of the latest stuff that's going on in medicine relevant to what we do at Precision, and so certainly, hopefully, give you tools that can help you just as you clinically continue in the practice of medicine. Thinking about this little installment of it, I just wanted to start at the basics, lay the groundwork that you guys all know, just sort of as a refresher course. We all need that from time to time. About documentation and just certain responsibilities as the provider in the clinic. So this is going to be a basic kind of run through of stuff that I know that you guys already know, but it's just good sometimes to have a reminder and a refresher course. Certainly Precision is its own unique entity. It is ambulatory, it is certainly outpatient, but it is not in the same vein as like a primary care doctor's office. So while it's not ER, it's not hospital, and it's not strict primary care or outpatient medicine, it's its own niche, and there are certain things to remember in that vein as well. Hopefully also, just as an aside, if this is helpful for you guys, what I would like to do is perhaps regionally set up something also quarterly where we can have either a Zoom call or a conference call with Lolita and myself so that we can address issues that are perhaps more pertinent to a certain region and not necessarily relevant to the Precision locations at large. So I'm eager to hear your feedback regarding that as well. Let's get started. Again, today I just wanted to go over some of the basics. We'll start with documentation. And I'd like to start with just a quick review of the purpose of documentation. It really is to convey to your colleagues your assessment and plan of care. It's to reflect the relevant data for that day's encounter, and to reflect your thought process and reasoning for a certain course of action and treatment. It's to convey to others, as well as yourself when you're looking back into the chart, what was going on that day and what you were thinking, and then what your plan of action was going to be and why you had chosen that plan of action. It's of course also to protect yourself legally. Again, you all know that if it's not documented in the chart, it did not happen. And ultimately, the goal is to facilitate excellent patient care and to communicate with our colleagues so that they are enabled to do the same. So when we're writing notes, yes, it's laborious, yes, it's tedious, but to keep that in mind, that this is really it's very, and it's an integral part of what we're doing in terms of taking care of our patients, is being able to communicate that efficiently and effectively to other providers, as well as ourselves in the future. There are different types of documentation, and the two that I'm just going to really touch on because they're the most relevant for us are the new patient visit and the return office visit. The new patient visit, of course, needs to be a little bit more detailed, a little bit more thorough than the return visit. It should include an extensive history of present illness and an extensive past medical history, so that whoever reads that gets a concise and yet complete picture of what's going on with the patient and what the patient's medical history, which of course includes the HPI, the past medical history, the past surgical history, hospitalizations, medications, allergies, adverse reactions, those kinds of things, as well as a thorough social history and family history. And then we want to see the subsequent A&P, assessment and plan, that shows your thought process and your plans going forward. Again, the caveat is that the infusion setting is a bit different than primary care. So we don't need to address every medical issue that they have unless it's particularly relevant to what we're doing in the infusion care setting. Certainly, if it's an aside that they have a B12 deficiency and we are giving them B12, that's a relevant thing to add in addition to the Entyvio or whatever that we're also providing for their ulcerative colitis. So you can be a little bit more focused in the A&P section as compared to maybe a primary care office, but it still needs to be thorough and quite complete in terms of the issues that we're dealing with at Precision. Then the return visit is meant to harken back to the new patient visit or the patient's visits prior to that date of service, but in a more focused manner. That means that you don't have to spend paragraphs going over the past medical history, explaining all of it. You just need to reference it, maybe 1 to 2 sentences at most, and then get on to the business of that day's encounter and what has brought them in that day. And of course, it also needs to include any pertinent history that has occurred since the last visit. So if they were hospitalized since you last saw them, or if they had a surgery or a complication or anything like that, a new allergy that has come about since you last saw them, of course, that needs to be included as well. We just want a clear continuum of the patient's history, almost reading it like a journal, so that somebody who picked up this chart could see piece by piece what's been happening historically in time, and not bog them down with details that they're going to find in other notes. Now on to some general principles regarding charting and just communication. Remember, your charting is your protection as well as the protection for your patient. If you do it, chart it. If you review it, chart it. If you communicate it to an outside provider, chart it. You don't have to be neurotic, but let common sense be your guide, because it is your protection and it's also the protection for the patient to document that you have done what you really have done. It's just a paper trail for that. And it's just the world we live in with EMR. Everything needs to be documented. Don't take anyone's word for it. It does not mean that you don't have that you have untrustworthy colleagues. You certainly do not. You have very trustworthy colleagues, but we are all human, and we all get busy. We get involved in things that happen acutely that we have to take care of, and things fall by the wayside. So if it's your responsibility at the end of the day, make sure that it has been done, even if you've delegated it. Just take ownership of your patient and the care that you're giving to your patients. Just also remember that the more hands that handle information, the greater the likelihood that it's going to get lost. Don't take someone's word for it and look it up yourself. If you've delegated something to be done, just circle back and make sure that it actually was done and that somebody didn't get tied up doing something else and it fell by the wayside. Ultimately, it is your responsibility as the healthcare provider in the office to make sure that that is done, and it's done effectively and in a timely manner. Let me give you a hypothetical. You have a certain very reliable referring doctor who has just increased one of your patient's doses of his medication. This medication happens to hold a risk of renal failure as a side effect. So this patient gets infused at the higher dose as per the doctor's orders and goes home with no known complications. This patient then has lab drawn in anticipation of the next infusion at that higher dose. And the lab notes that he has a substantially increased creatinine and a decreased GFR, which you guys all know is a red flag for acute renal failure. This patient then presents again for a repeat infusion, and you see the lab and you think, oh, this is a little worrisome. However, we have a note from the referring MD, and he's the specialist, and he doesn't tell us that we need to dose reduce in light of the lab findings. Well, the labs were sent to him, and he's the specialist, so he knows what he's doing. So you go ahead and infuse. Come to find out that this very conscientious doctor did not ever see the lab because the AEL lab employee forgot to fax it over to that doctor's office as well, and the nurse who works there got bogged down and didn't remember to check up on those labs, and so he didn't know. So when he sent his latest office visit note to you guys for review, it doesn't reference it because he didn't see it. So we're operating under the assumption that he's okay with continued infusion at the higher dose, but that is erroneous as he has not seen the lab value, and now you're in danger of throwing your patient into irreversible renal failure. This of course is a hypothetical situation, but these things happen, and things similar to this have happened, and I have seen them happen around me in the hospital setting, as well as the acute care and primary care settings. So it's really important that we confirm. If we have a concern, that we confirm it. If you see a lab and something doesn't quite add up, call that physician. In this instance, you should have called the doctor's office and said, just double checking, make sure he saw that the creatinine doubled, and that we want to continue the infusion at this increased dose. You can save yourself and him a lot of trouble, and certainly you will be protecting your patient in the most acceptable and optimal way. A caveat about labs is that all lab aberrations do not need to be phoned in to the referring physician. If you have a patient with known thrombocytopenia who hovers around 90,000 platelets and consistently comes in, and it ranges 110 sometimes it's 85, and you have a patient who comes in and it's 80,000. If they are consistently thrombocytopenic, the referring physician is aware of it. That's where they live. And that does not necessarily merit an immediate call to the physician's office to make sure they're aware that the platelets are yet again low. A great resource is actually looking back at the prior notes sent from the referring physician, because oftentimes they'll reference that. And so it gives you another backup in terms of, yes, this person has known thrombocytopenia, he's being treated for this by hematology, we're okay proceeding. Again, if you have a patient whose platelet count is usually 250,000 and they come in and their platelets are 110,000, and especially if you're giving them a medication that certainly can be toxic to platelets, you need to get on the phone immediately with that referring MD and make sure that he is not immediately, semi-immediately, semi-urgently, to make sure that physician is aware, especially, of course, if we are giving him a medication that would potentially be toxic to platelets. Certainly, any lab finding that we find that is worrisome for our patients, don't assume that the physician who has ordered that lab has either taken care of it or is aware of it. The lab was drawn in our clinic. You have laid eyes on it. It has come to you. You are now responsible for that information. Now, ultimately, you don't maybe need to treat that, but your eyes have seen it, and now you are responsible for the information that you have seen, and you need to make sure that that patient is aware and that the referring or the ordering MD is also aware that it has not gotten lost and that there is a plan. And sometimes it may merit you calling a patient saying you need to go to the ER. It's going to be much less likely that that's going to happen, but we give very toxic medications, and we have to take some ownership of that as well. If y'all have more questions about lab, we can certainly discuss that at another time. I know the Memphis Clinic and I have discussed it because they do draw a lot of labs, and what some of the nurse practitioners are finding is helpful there is to keep a list of the labs, the patients that they're drawing labs on, and so that they remember to check back the next day, so that they can get the lab values and just review it. We're going to get into this a little bit more in just a minute. The next thing I want to just remind you guys, and you'll know this, but just as a way of reminder, careless or imprecise documentation is absolutely never acceptable. Make sure that what you are putting in the chart is accurate and up to date. Make sure when you check that box that says there's no new medications added to the formulary, that indeed no new medications have been added to the formulary. One little problem area that I'm seeing is with methotrexate, and I think it's just wedged in there and you guys don't see it. It's oftentimes checked no, and it is very clear that the patient is taking methotrexate. You can find this in the formulary on We Infuse. You can also find it oftentimes in the referring physician's office visit notes that are in the chart as well. So just be really aware of that. Any kind of misinformation like that, especially basic stuff like that, calls into question the entire veracity of the chart, and it exposes you guys. So it's really important that what we write is accurate and reflects the most current information on the patient. Another potential problem is cutting and pasting. And EMR is a blessing and a curse. I tend to think it's more of a curse than a blessing, but it is not going anywhere. It is here to stay. And there are pitfalls that are specific to EMR. With the very, very, very rare exception, absolutely no note should be cut and pasted in its entirety. There is no situation really actually that I can think of where that should be an acceptable thing. I have come across notes also that sometimes will have information that talks about a doctor's appointment that's coming up in December, and the note is dated January, February, March. So clearly that is outdated information. And again, it makes the person who has authored the note, it calls into question everything else that they have put in the note, because clearly if they weren't paying attention to that, what else in the note is not accurate? It's a danger with cutting and pasting. So I just want to give a very clear warning. We're all busy. I know charting with EMR is difficult, and I know there are some challenges specific to precision, and we are working. My understanding is that there is an active, ongoing plan to try to make that a simpler process for you guys, because I know it has not been simple these past few months. Regardless, let me reiterate, we really cannot have cut and pasted notes. There are too many errors that come in. So keep that in mind. Additionally, there's also just no reason in the world that there should be a handwritten note in scanned into the chart. There is a standard that has been established. There is a template that has been established. If we need to fix some of that stuff, let us know. But it needs to be typed. It needs to be organized, and it needs to be original. So bear that in mind when you're dealing with charting in the EMR. Okay, so beyond that, a few reminders of important elements to make sure that you're including in your charting. I referenced this just a few minutes ago, but any correspondence that you get from a referring MD, it needs to be reviewed, and it needs to be documented that you reviewed it. Simple sentence: referring MD's latest office visit note reviewed, period. It doesn't have to be lengthy. Sometimes there may be some pertinent information that you want to add after that, but generally speaking, it just needs to be reviewed. I'm sure you guys are reviewing it, you're just not documenting it. And it's not a problem, but going forward, it does need to just at least be referenced. If you are not reviewing the referring MD's note, you need to start doing that. It's a part of the chart. It's a part of the patient's, the care of the patient. And there can be very, very important and relevant information found in that referring doctor's note. Let me give you another hypothetical example of that. You have a patient who comes in and sometimes gets nauseated, and you pre-medicate with Phenergan. Never had a problem, not a problem. They do well, they go home. You don't read in the chart the referring MD's most recent office visit note, which references the fact that the patient had a dose of Phenergan outside of precision, and as can happen with Phenergan, had a seizure that was related to it, was in the hospital. Very clearly delineated in the referring physician's note that this patient now has a Phenergan allergy. Well, you are busy and you haven't reviewed it yet, and the patient comes in and gets a little is a little nauseated, and so you go ahead and give that dose of Phenergan that you're used to giving and that she has tolerated for 3 years, not knowing that she has developed a adverse reaction to Phenergan, and she has another seizure. And quite frankly, that is now on you, because it was documented. And we know that patients do their best, but they are oftentimes terrible historians. And we don't have to just rely on the patient's memory or history. We have most of the time or oftentimes a referring doctor's note that is going to say, this is what happened, this is a new allergy. And had that been read, that whole episode would have been avoided, and of course the patient would have not had that adverse event. Just another example of how to safeguard yourself and safeguard our patients. It's just important to be on top of all that's been going on with our patients, and to realize that sometimes, great as our patients are, they are not always the best historians. You all have had the experience of having an encounter that lasted 20 minutes and about to leave the room, and the patient says, oh, by the way, I forgot to tell you that I've just been diagnosed with colon cancer. Then you go back and sit back down and start again. We know that patients are not always the most reliable and don't always have the best memories. So we have to rely on other things. And if you have it in front of you in the EMR, definitely read it, definitely review it. It will save everybody a lot of trouble if we do that. The caveat is you do not have to reference that you have read every single office visit note from the 3 years that they have been there. If they have, if you were reading the most up-to-date, that should suffice. Certainly there may be situations where you need to go back and do that, but that is not every note that you're writing. Just reference the most recent office visit note from the or lab or whatever correspondence from the referring doctor, and that should suffice. Again, referencing labs, make sure that if you've reviewed it, that you chart that you have reviewed it, and you should be absolutely 100% reviewing your patient's labs. They are drawn in our facility. They are drawn under your watch. You are responsible for them. Therefore, when you review that patient's lab, just put a quick note. If everything is there's nothing really to report, just say labs drawn, data service, reviewed, period. If there is something a little concerning, patients developed new microcytic anemia, will correspond with ordering MD for any change of plan of care, period. Simple, but needs to be done. And I know you guys know this, but I just want to reiterate that because that is standard of care, and it's you guys earned your degree to do just that. So make sure that we are doing that on a consistent basis. of course, you'll know any adverse event that occurs while the patient is at Precision or directly related to something that happened at Precision, an infusion or an encounter or something. Make sure that's also documented, and you guys are doing that beautifully. And document it in real time. That's the best. That's the best way. Don't come back a day later and say, oh, yesterday we had a patient who had to go by ambulance. Document it in real time. Okay, now on to professionalism in the workplace, which again is just a review for you guys. Y'all are all very professional and do very good work. I'm glad to be working with all of y'all. But as a reminder, and again, this harkens back to how difficult EMR can be. I know that's the case, but you need to complete your charts in a timely manner. And for the most part, this is not a problem. It's just more by way of reminder. It needs to ideally and typically, with very few exceptions, it needs to be done the day of service. There's really not much of an excuse for it being entered into the computer days after the encounter. That, of course, is to protect you and, of course, to protect the patient as well. Make sure that you come to work on time and you leave when the work is done. This is, I'm making this statement vague for a reason, because some of you are salaried and some of you are part-time, some of you are hourly. You should stay until the expected paid time period has expired for those of you who are salaried. No question about it. If you are salaried and you're salaried for a 40-hour week, you need to be working 40 hours a week. Sometimes the day ends early, and that's great, but you need to stay because you are being paid for that time period. There is always stuff that can be done. You can always follow up on labs, check up on patients. There's usually almost always something that can be done. For those of you guys who are paid hourly, make sure that you're not staying at work when there's no work to be done, because you know you can get paid a little extra. Or conversely, possibly working more slowly on charting or more casually on charting, because it doesn't matter because you're paid by the hour. Both scenarios, both with the salaried and with that hourly employee, those kind of scenarios that are, of course, hypothetical, they actually are time theft. You are actually stealing time that you were paid for from the company, and it's just not professional. Certainly there are very rare exceptions to the rule where one day you're having to you may have to stay late. And we understand that does, of course, happen because we're dealing with patients and human beings. Work that out amongst yourselves so that you are not, if you're salaried, ending up working 50 hours a week or whatever. That's not acceptable either. And be sure to communicate that with either Lolita or myself if that becomes a consistent problem. But in some respects, it has to be a little fluid because, again, we are dealing with patients and they don't always respond exactly as we want them to. But it needs to be an underlying understanding that we need to do the work that we're paid for and the hours, the time that we're paid for. And you guys are hard workers. I know that. It's just by way of reminder. And again, to also remember that not all of you are salaried. Some of you are salaried and some of you are hourly. So you can't necessarily compare yourself to others because your pay situation may be different. Again, this is basic stuff, and I know you guys know this, but it does bear repeating. And if there are abuses, we need to know about it, and we will do our best to get to the bottom of it. In the same vein, remember that we are operating as a team. Medicine is ever more a collaborative endeavor, and we have to collaborate with each other. We have to communicate with each other. We have to help each other. It's essential that we lay aside our egos and sometimes even our degrees to work collectively. It's for the good of the patient, it's for the good of the clinic, and ultimately it's for the job satisfaction for all of us. sometimes you as NPs are going to call on to do stuff that's nurses' duties. You will occasionally need to work as a front desk person or a janitor. And these are the exceptions to the rule, for sure. They are the exceptions, but they do occur occasionally. Don't be too important to clean up a spill or mix a drug. We are working as a team for a common goal of excellent patient care. We want our patients to do well. And sometimes on crazy days, we just have to step in and do stuff to help each other out. Do the task that it will take you just a few seconds to accomplish, but that would take you 5 minutes to go find the person who's supposed to do it to accomplish. That being said, you are not continually to be called upon to do your job as well as that of housekeeping, nursing, or secretarial staff. All jobs are needed, all jobs are valued, but not all are your responsibility. It's a balance when you're working with a team of people, and communication, again, is essential. Help when it's needed, but speak up if there are abuses. Our goal, again, is excellent patient care. And we want to collaborate with each other. We all have our roles, but we want to make sure that you also are not being abused in that capacity. But remember that you're not strictly just doing the job description of a nurse practitioner. There are some days when you're going to have to function as a nurse for a specific incident. And then again, if that becomes a pattern of behavior, you need to let Lolita know or me know so that we can remedy that, because that's not what you're called upon to do on a consistent, regular basis. Again, communicate with each other just as you are communicating with your referring MDs. Y'all are all colleagues and you're a mutual resource for one another. And especially you NPs together, because you don't necessarily see the same patients every single time they come in. And so work with each other and recognize that if you're going out of town, for instance, and you've seen a patient and he's coming in the next week, and oh, by the way, he has white coat syndrome and his blood pressure goes up, it would be nice to alert your colleagues who are going to be in the clinic when you're out of town, hey, Mr. X is coming in next week. Y'all don't worry if his blood pressure looks really high. He has white coat syndrome. If you check it in 30 minutes, it'll be down. That saves them a whole lot of headache and time, and helps us deliver more efficient and quality patient care. Those little things, just working collaboratively, will make a big difference. Again, the ultimate goal is to work as a team player so that we can just provide the best care that we can to patients. And let me say, as I'm finishing this up, you guys do provide really excellent care to these patients. I know because I've heard from the patients, and I have seen it with my own eyes. I am grateful to work for a place where patients are valued and they are treated with such respect and such care. I'm so glad for these patients that they don't always have to go into a hospital setting to get their infusions, especially the ones who have to come in with great regularity. And you guys deliver excellent care. These are all just talking points by way of reminder, things we can brush up on, things that we can do a little bit better, some things that are not an issue now, and we don't want them to be an issue. But I want to reiterate that you guys are really doing a great job, and your patients are so appreciative of the care that you deliver. Again, I am a resource for y'all. Lolita is an excellent resource. I know y'all avail yourselves of her. I want to hear feedback. I want to know if this is helpful, what topics y'all would like to discuss in the future, because I do want to do this on a quarterly basis if it has been helpful. Also be thinking about if you think it would be helpful for regional meetings, either through Zoom or conference call or however. Because I know that there are things that are specific to your region or your locale or your patient population, whatever, that you might want more specific collaboration about. So I am delighted to be at Precision. I'm delighted to have met most of you and to get to meet some of you in the near future. If you need any of my contact information, I think most of y'all have it, but you can certainly get it from Lolita, or I can send out a general email with that. I think most of y'all have it. Keep up the good work. I am proud of all the work that y'all are doing and am here for y'all when you need it. Take care.